Pathology. The lung. Developmentally, the respiratory system is an outgrowth from the ventral wall of the foregut. Midline trachea develops from two lateral pocketings, the lung buds. The lung bud eventually divide into branches called lobar bronchi, three on right and two on left, thus giving rise to 3 lobes on the left and 2 lobes on the left. The lobar bronchi have firm cartilaginous walls that provide mechanical support and are lined with columnar ciliated epithelium with abundant superepithelial glands that produce mucus, which impedes the entry of the microbes. Aspirated foreign materials such as vomitus, blood, and foreign bodies tend to enter the right lung more often than the left. Except for vocal cords, which are covered by stratified squamous epithelium, the entire respiratory tree, including the larynx, trachea, and bronchioles, is lined by pseudostratified tall columnar ciliated epithelial cell. The bronchial mucosa also contains a population of neuroendocrine cells that have neurosecretory granules and can release a variety of factors including serotonin, calcitonin, and gastrin-releasing peptide. Numerous mucus-secreting goblet cells and submucosal glands are dispersed throughout the walls of the trachea and the bronchi. Microscopic structure of alveolar wall. Congenital anomalies. Developmental anomalies of lungs are rare. Pulmonary hyperplasia is the defective development of both lungs. Foregut cysts arise from abdominal detachment of primitive foregut and are most often located in the hilum or middle mediastinum. Pulmonary sequestration refers to discrete area of lung tissue that lacks any connection to the airway system, has an abnormal blood supply arising from the aorta or its branches. Atelectasis. Atelectasis refers either to incomplete expansion of the lung or the collapse of previously inflated lungs, producing areas of relatively airless pulmonary parenchyma. Reabsorption atelectasis stems from complete obstruction of airway. Compression atelectasis results whenever significant volumes of fluid, tumor, or air accumulate within the pleural cavity. Contraction atelectasis occur when focal or generalized pulmonary or pleural fibrosis prevents full lungs expansion. Various forms of atelectasis. Significant atelectasis reduces oxygenation and predisposes to infection. Atelectasis is reversible except in contraction type. Pulmonary edema, leakage of excessive interstitial fluid which accumulates in the alveolar spaces. Pulmonary edema is divided into hemodynamic edema, edema due to alveolar wall injury, edema of undetermined origin. Hemodynamic edema can be due to increased hydrostatic pressure, which is present in left-sided heart failure, volume overload, pulmonary vein obstruction, or due to decreased oncotic pressure, or in hypoalbuminemia, nephrotic syndrome, liver disease, protein losing enteropathies, or it may be due to lymphatic obstruction. Edema due to alveolar wall injury may be due to direct injury, infections, inhaled gas, liquid aspiration, radiation, or may be due to indirect injury, for example in septicemia, blood transfusion, burns, drugs and chemical, shock and trauma. Maybe due to undetermined origin, for example high altitude or neurogenic. Acute lung injury and acute respiratory distress syndrome. Acute lung injury, non-cardiogenic pulmonary edema, is characterized by abrupt onset of significant hypoxemia and bilateral pulmonary infiltrates in the absence of cardiac failure. Acute respiratory distress syndrome is manifestation of severe ALI, diffuse alveolar damage, the histological manifestation of ALI and ARDS. Condition associated with development of acute respiratory distress syndrome: infection, physical injury, inhaled irritants, chemical injury, hematological condition, other. Infection can be due to sepsis, diffuse pulmonary infection, gastric aspiration. Physical or injury, mechanical trauma including head injury, pulmonary contusions, neo drowning, fat embolism, burns, ionizing radiations. Inhaled irritants, oxygen toxicity, smoke, irritant gases and chemicals. Chemical injury, heroin, methadone overdose, acetyl salicylic acid, barbiturate, paraquat. Hematological condition, transfusion associated lung injury, disseminated intravascular coagulation, other. Pancreatitis, uremia, cardiopulmonary bypass, hypersensitivity reaction. Pathogenesis, endothelial activation, then addition and extravasation of neutrophils, then accumulation of intraalveolar fluid and formation of hyaline membrane, then resolution of injury. Normal alveolus compared to injured alveolus in early phase of acute lung injury and acute respiratory distress syndrome. Diffuse alveolar damage. Clinical course: profound dyspnea and apnea with ALI, followed by increasing cyanosis and hypoxemia, respiratory failure, appearance of diffuse bilateral infiltrates on radiological examination. Hypoxemia may be refractory to oxygen therapy due to ventilation, perfusion mismatch, and respiratory acidosis can develop. Lungs become stiff due to loss of functional surfactant.